showing us connecting his audio.
Yeah.
Dr. Archana also is connected.
Okay, good.
Good evening, Dr. Archana ma'am. Prasad here from Genesia Shield Healthcare.
Hi, Archana,
Hi, Amit.
and thank you so much for joining.
Oh, it's pleasure always. Hi, Sarita.
Yeah, you need to meet Mr. Prasad.
Namaskar, ma'am.
Hi, Mr. Prasad.
Hi, ma'am. Good evening.
Good evening. How is the weather in Mumbai? It's very cold here. It's chilling cold.
For us, it is cold, although it goes only to 15 degrees minimum.
It is
For Mumbaikars, we all feel, my God, it's so nice and pleasant.
here. It is. You know, bone hitting to the bone 7 degree.
Okay.
Wow.
So I mean, you know, like you have to find. We are also not used to 7 degree in the whole day. In the night, okay, you are already in your blanket and all, but in the daytime, even working, you are like shivering.
But this will stay in Mumbai only for a few days.
Okay.
We'll all get very.
So, good evening, Dr. Gulam.
Hi, Gulam. Good evening.
Good evening, Dr. Gulam. This is Dr. Sarita Bhalerao.
Hi,
Sorry,
Dr. Archana Basir.
can you see me? I don't think you can
We
actually.
can't see you, no.
We could see your screen share, sir, which you have shared. I request you can stop it for some time. And first, I'll introduce.
You can minimize it and keep it. Stop screen share and minimize. Yeah. So,
Yes. So, I think, can we start, sir? We are already
yeah.
5 minutes.
Gulam, can we start?
Of course, I'm just trying to, I don't know why it is slow here, but I'm just trying to get the video back on here. Can you see me or not?
No, we cannot see you.
Your camera is not on, sir, possibly.
Okay, so that's the first thing I can do.
Yeah, we could see you now. Definitely.
Good evening.
Good evening.
Good evening, everyone.
Thank you so much for accepting our invitation.
Well, I'm most grateful for the invitation.
I must thank Anil. I've worked many years back at Homerton during the days of Richard Howell. And we used to have Sammy Lee then coming as an andrologist. But this is going back in 1995, 98.
What a blast from the past. And Anil has, Dr. Anil Goody has spoken to me very highly of you.
Thank you so much. Let me introduce you to Sarita, who's the chair for the RCOG West Zone. She's been over from me last month.
Nice to meet you.
Nice meeting you all. I can't see all of you, but I'm sure there must be at least 20 in the crowd.
Yeah, no, there is.
This is just a speaker link.
This is a speaker's link, sir. The link for participants is different.
Oh, okay.
We will tell you the
exact. We started the meeting or not yet?
No, we will start the meeting now. Since you are joined in, we will all mute ourselves and we will start the meeting. And you are the first speaker.
Okay.
All right, fine. So Prasad, you can
start. Sir. I'll take it. So good evening, all of you doctors. Welcome from Shield Healthcare for this webinar. And I profusely thank Dr. Amit Patki for taking the initiative to take through. And I welcome Dr. Sarita Bhalerao ma'am, who is chairperson for today, and also Dr. Archana Basir for being a chairperson here. And I profusely thank Dr. Gulam Bahadur for accepting our invitation to be a speaker for us. It's an honor for us. Thank you so much for being here. And I take pleasure, and I also invite all the participants for this international webinar. And I take pleasure in introducing our two chairpersons today. Dr. Sarita Bhalera, who has done her MD, DNB, and FRCOG, and obstetrician, gynecologist to Breach Candy and Reliance HNH Hospital and Saifi Hospital, Bhatia and Wadia Veterinary Hospitals. And Dr. Sarita Bhalera has been quiz committee chairperson Foxy 2009-2011 and joint secretary Foxy 2017 and immediate past president at AMWI Mumbai branch and Vice President MOGS for the current period 2020-2021. Past Chapter Secretary IMS Mumbai Chapter and member of Governing Council ICOG 2018 to 2020 and Chairperson AICC RCOG West Zone. Welcome, ma'am, Dr. Sarita Bhalera.
Thank you, Prasad, for that kind introduction. And at the outset, I must thank Dr. Amit Patki for giving me this opportunity. I think you go ahead and introduce Dr. Archana, then I'll start.
Yes, ma'am. And I also take pleasure in introducing Dr. Archana Basir, who has done her MS DNB, FRCOG, FICOG, consultant obstetrician and gynecologist, director at Akash Hospitals Indore. And she has won Guinness World Record for Guinness World Record holder for who has removed largest uterine tumor. Congratulations, ma'am, for that accomplishment indeed. And she was also Vice President Foxy 2020, and she has been organizing secretary ACOG for 2021 Indore, and fellow representative AICC RCOG West Zone, and Imaging Science Committee Chair SAFOG. And past positions, Chairperson Foxy Imaging Science Committee 2015 to 2017. Thank you, ma'am, for being with us as a chairperson for today's event. Welcome,
ma'am.
Thank
you, Amit, for inviting me.
Thank you, ma'am. And if I have permission from all of you, I'll take about a minute or two to launch proudly our Shield Connect webpage, ma'am. And after that, we can take through the program for this day.
Sure. Please go ahead.
Thank you, ma'am. Chitrala, can I have the AV, please, for Shield Connect? It's a digital initiative we have started, doctors. Thank you, doctors. This is our web page wherein, with your consent, we will have all the webinars which are hosted by us. So by topic, by speaker, you can choose to view, ma'am. Also your students, your juniors, all of them can see. And we are also now a step forward, creating one single page for each of the eminent speakers we have, like Dr. Amit Patki sir, we have created one. So that link will only take to Dr. Amit Patki sir's webinars held by on the Shield platform by us on the Shield Connect web page, doctors. So it's a digital initiative for missed socializing events, and for this academic support we wanted to do for the doctors faculty. Yeah, these are all the webinars we have. Roughly about 300 webinars we are currently hosting on our web page, doctors. So now may I request, yeah, you can stop share. Now may I request Dr. Sarita ma'am to introduce Dr. Bahadur sir. I'll share the screen here.
Hello.
Yes, ma'am. You can go on. I request you to introduce our speaker, Ghulam Bahadur sir. Ma'am, am I audible?
I'd like to introduce Ghulam Bahadur, please.
She got logged off by any chance?
Archana, would you like to introduce Ghulam
Yeah,
Bahadur? Yeah.
certainly, certainly. Mr. Prasad, can you put Dr. Bahadur's CV here, or this
This
is
is the
only...
one. This is the one, ma'am. What you are
Okay.
seeing is the one.
Well, thank you so much for giving me opportunity to introduce our speaker for today. And it's my proud privilege to be here on this platform. Dr. Ghulam Bahadur is in reproductive medicine work clinic, North Middlesex University Hospital, London, and he is one of the best. I've heard him in the past as well on male factor infertility. What he is going to be talking to us today is contemporary male factor infertility leads to improved patient treatment outcomes, and we welcome Dr. Ghulam Bahadur on this platform of All India Coordinating Committee of Royal College of Obstetrician and Gynecologist, Western Zone. And on behalf of myself and my co-chair, Dr. Sarita Bhalerao, I welcome you here, and floor is all yours, Dr. Ghulam Bahadur.
Sarita, would you like to add something?
Ma'am, you need to unmute. You are still on mute, ma'am. Dr. Sarita.
Yeah, no, I'm sorry, I lost network in the middle, so I've logged back in. But I thank you, Dr. Archana, for introducing Dr. Ghulam Bahadur, and know that he's a authority on this subject, and that we're all looking forward to listening to his.
Ma'am, can you introduce Dr. Amit Patki, the second speaker for today?
Is Sarita, or let me?
Sarita,
I think Sarita is going to compile up all the talks. So I think she's losing her network in between. I think it's really give me a great pleasure to introduce a great friend and a great human being, Dr. Amit Patki. Amit is a wonderful person. I have known him for last, I think, more than 25 years. And he is medical director, Fertility Associates, Mumbai, honorary associate professor, KJ Somaiya Medical College and Hospital, is consultant, Khar Hinduja and Surya Hospital, Mumbai, and governing council member, ICOG, vice president, SR, general secretary, MSR, his chair, West Zone, RCOG, 2015 to 2019. And we have seen the tremendous amount of activities were done while he was chair, West Zone, RCOG. He has 35 publications in national and international journals, 50 book chapters, and editor of 3 books. He has 2 international patents in infertility and stem cell research, and is a TEDx speaker. And if you many would know, he is like the creator of Legends in Gynecology, which is a very popular series, and many viewers on that, and it's wonderful series to watch. And Amit is a great speaker and a we're looking forward to listen to the Amit as well after Dr. Ghulam Bahadur.
Dr. Ghulam Bahadur, what do you say for your lecture? And after that, Dr. Amit Bhakti will take, and then the questions by Dr. Prachi from our medical advisory department. She is heading our medical department.
Well, Dr. Amit Patke and your team, I'm most grateful that you've invited me to give this talk. It looks like a very privileged platform also. So I've been told by your friend, Mr. Anil Goody, who is also a close friend of mine. So I'll begin my talk by the title that you've given me is Contemporary Male Factor Infertility, Understanding Leads to Improved Patient Treatment Outcomes. It's a very difficult talk in a way to do, because you're trying to bring on quite a lot of issues together. Now, I've borrowed quite a few slides from different individuals, so their company logos might show on it, but I'm grateful to them for all the people who have provided me with different slides. I've had to lean on a historical background in so much as, and I borrowed something from William Shakespeare, All the World's a Stage, where they define the seven ages of man. And one interpretation of that is to the left, and on the right is the way our field looks at the age of man. And sadly, it is stuck in man the sperm, not man the patient or man the man. And I think this is something that will come to the fore later on. At the moment, we are all simply homed in on the WHO criteria. I'm trying to reduce. I need to see my slides. I don't see them fully because there's so much other stuff on it. And we seem to be just narrowed down to sperm count, sperm motility, progressive and morphology, and that's and the various WHO manuals. This is not man. This is perhaps a very narrow view of things. Now, sperms are very, very interesting because they're always in excess, and it's not a rate limit. It's not a limiting factor. There's genetic uniqueness in each sperm, which provides a wide variety of phenotypes. So within the same ejaculate, and there's no repair machinery, and we have to rely on the women to repair the sperm here. And each sperm is very, very different, and from the complexity you can see, starting from spermatogonium right down to the spermatocyte, there are many, many replications, divisions and replications taking place, and until they reach the full spermatozoa, and they're released into the lumen of the seminiferous tubule here. Now, within each of the meiosis, for instance, there are still many what you call steps, at least about 4 to 5 more steps involved here. And when you begin to sort of count when you begin to count all the steps here within the 74-day maturation cycle, it has undergone several hundred divisions and replications already. So we can think in terms of going for more than a year, or about a year. It really does amount to a lot of divisions and replications. And what you end up having as a result is that there's a risk to the genetic factors here. In terms of the sperm itself, we know that there are evident abnormalities in terms of count, motility, and morphology. But what you don't see is what the chromosome level is. You don't see what the DNA integrity is, and we have some molecular factors that are ascribed to fertility and infertility factors, and they're yet undetermined and unknown molecular factors that are, so basically these are hidden abnormalities which you don't see and are becoming more and more important. To the left, we see what is there for the man, and to the right, there's a complexity of what is involved for the woman. So in terms of the man, what else are we, can we look beyond that sperm analysis? And when we begin to look at, when you begin to look at some of the just reproductive factors alone, virtually every aspect is, for instance, the many various reproductive, that there's a risk of ischemic heart disease, for instance, and you can go down the whole list and see what sort of reproductive factors will affect that. And then going on to the man himself, there's a genetic, there's a incidence of prostate cancer for men who have, I mean, these are men who have helped achieved with their partner a natural conception versus men who have achieved conception with a partner using IVF and ICSI, and you can clearly see that there's an excess of what you call prostate cancers there. And so men fathering children through ART procedures have a 30 to 60% increased risk of prostate cancer compared to men conceiving naturally. And they have almost twice the risk of developing an onset of prostate cancer before the age of 55 years of age. And men fathering children through ART seem to be at an even higher risk of prostate cancer. So the benefits of prostate cancer screening should be considered in this group. Similar for the, it's just a shame because for some reason I've got, now I'll be able to see my slides better. If we look at testicular cancers, there's an increased risk of testicular cancers. And in oligozoospermic men, we have a much higher risk of testicular cancer, and there's a strong association with oligozoospermic men based on concentration alone. But this specific study did not show the association between azoospermia and an increased risk of testicular cancer. But let me, I'm sorry, but my slide's not moving. Okay, so in the next study was an Eisenberg study. There is an increased risk of testicular cancer for azoospermic men compared to non-azoospermic. And when you come to this first degree and second degree relatives of men with poor sperm semen quality, there were increased risk of testicular cancer there. And with azoospermic men, there was also an increased risk of testicular thyroid cancer. And here we see the whole variety of chronic medical conditions associated with the infertile men. Because the slide is very busy, I picked up the diabetes, renal ischemic heart disease, and liver here. And the use of ICSI per se has been increasing steadily over the years. And it is understandable that for male factor infertility, that there's a virtual plateau there, but for non-factor, that has been increasing. I don't know why it's sticking. Okay. So here are other situations whereby there It's just a breakdown of the previous slide. So is there an increased use of ICSI because there's a genuine male factor in fertility, really? Is it because doctors are recommending, or is it a patient's choice? Is there fear of failure on the parts of the clinics, or is it the patient who is fearing that I cannot afford to have a failure and hence pick ICSI and choose ICSI? Is there increased profits involved? Is that a factor? And that is there a treatment over culture, a culture of over treatment? And that leads on to other things like cryopreservation and add-on costs. And if you look at how different countries are operating, some like in the UK at the bottom, we've got roughly a 1-to-1 split between ICSI and IVF, but in many other countries, my goodness, if you look at it, it's really up to over 80%, which I think there is something not quite right here. The position I use the old adage, because you can, doesn't mean you should. And I think, and I'll show you some very good reasons why you should not be doing as we go down the talk. And what it is that ICSI does not confer any benefit in the absence of male factor subfertility when compared to IVF. And this paper has recently been published here saying just the same thing. And as far as ICSI and the risk of major birth defects go, yes, there's an association, and yet, and again, this paper has been recently been published. And what it shows is that there's for the risk of major non-chromosomal birth defect is that there's an 18% increase in singleton infant conceived without ICSI, but there's a 30% increased risk with ICSI without male factor, but a 42% increased risk with ICSI and male factor here. And so there is a position that there is the paper supports a judicious use of ICSI only when medically indicated. And it is unclear as to why I mean, there are clearly cases where people are pushing, some clinics are pushing difficult cases onto IUI, suggesting that your results will not be any better should you do IUI. So now IUI is actually facing pressure from even more and more difficult cases. In terms of the biological explanation that may follow is that there's inherent genetic factors, hormonal factors, in utero factors, social factors, lifestyle, health factors. These are all possible contributors to why there are excess abnormalities. But there seems to be a little bit of bias in the created artificially, I believe, in the IUI group here. And the ASRM position is that largely it does not support the use of ICSI in beyond the male factor, where it is needed, and that severe male factor condition here. So, and also the liberal use of IVF has extended to mild male fertility, endometriosis, and unexplained infertility. And in the Campius paper, just in 1 year, you could see a 290% increase in the diagnosis of severe male factor infertility. In the paper that I presented at ESHRE on IVF and IUI, in that specific study, the male infertility is 37%, which is much bigger than the unexplained. So between them, they would be actually be using that to justify ICSI procedures. And the term mild male factor infertility is extensively used in the practice and in literature, and but there's no formally recognized definition that is currently available. So if you think in terms of what I have spoken so far is that infertility and health are correlated, and we spend billions of pounds to try and find early diagnosis of various diseases, and yet they're sitting right in front of you. Infertility, patients that are subfertile, where you could begin to be looking at early diagnostic markers, or certainly be investigating them for a variety of things like cancer, cardiovascular disease, metabolic immune disorders, and other things, or also other cases here. So men as sperm vendors for ICSI is actually creating a major disservice because it fails to investigate the male fully at a clinical level. It affects future generations' health. There's a wider health investigation, and there's a loss of patient care and autonomy. And you see, you begin losing male fertility research investment. And that the increasing use of ICSI with normal sperm actually masks and nullifies the true side effects. That's what I find. And here we've got side effects which are quite big in terms of casual use of IVF, and that is OHSS and the add-ons. And then I've also dwelled on the real cost effectiveness of procedures, of various procedures, which has gone up totally amiss. And the increasing reports that ICSI babies are different from IVF babies. Frozen embryo transfer babies appear to be much bigger weight. And I don't know whether that's got something to do with IVF procedures, and is that there's a marginally increased dizygotic twinning, and whether that's again related to laboratory procedures remains to be seen. And paternal health is associated with a higher risk of pregnancy loss when you have 1, 2, or 3 comorbidities. But that is quite clear that you can see the pregnancy loss there. If I have to now dwell on what is the most natural environment that man is subjected to, and that is aging. And if we see that over the years, the number of de novo mutations in the chromosomes increase with age, and if you have to add an outside insult to radiation or anything else for that matter, you can induce the apoptosis, and the ones that concern me at this stage is that DNA double strand breaks here. And something that's close to my heart is the health of men with cancers, and whether chromosomal aberrations can be induced in male germ cells by genotoxic exposure and transmitted to offsprings and future generations, with effects on the development, fertility, and health. And we want to know that if a man begins his chemo, at what stage, at what part will the DNA be damaged, or will it be damaged at all? And it transpires that late meiosis is the most sensitive place where you are likely to cause that sort of damage here. And these are 6 patients from 6 Hodgkin's patients, where you see these structural chromosomes and the numerical chromosomes aberrations is quite high. The little black dots here are your controls here. So again, what I said earlier, it was a late meiosis stage that are affected, as you can see in each of these 4 graphs below here. So is there a way we can repair them? I mean, our nurse at North Middlesex, she puts just about everyone on men and women on Proxeed, and whether there's any science or logic, we will discuss that in a moment. We hope that that whatever is happening can begin to have some sort of reduction in the kind of damage that occurs. I'm sorry, I'm having difficulty. Yes, okay. So we hope that with Proxeed, it will help increase the sperm energy metabolism, and that it will minimize free radical damage, and it will help improve the maturation process of both the sperm and the oocyte, and the components of this are to the right. Now, this is where I have some trouble with, because people are just concocting things willy-nilly, and sometimes without the research. And I have to give credit to these lot, is they do quite a lot of research on sperm, and have come up with a nice balance here, because adding one more in excess may actually be toxic. So when looking at the sperm itself, you have the environmental and the systemic pathologies to consider, those kind of pressures that are on the sperm, and in terms of the diseases, and the overall position is that with the insult of oxidation, the oxidative stress, you're going to have damage to the sperm. And is there a way to evaluate that damage? And certainly it looks like antioxidant supplementation may well be one possible answer. And in their studies, they have looked at there's a much higher incidence of sperm abnormalities with a very high aneuploidy rate for the oligoactinoteratozooospermic men. And there was, in terms of controls, there was far less damage there. So in treated groups, we found they found that the aneuploidy rates were much lower, and in other scenarios, the reactive oxygen species and the total motile sperm counts were much more favorable after the treatment. Again, looking at the oocyte, we have as much, the women are subjected to the same insults, environmental insults, and the daily insults that the man has. And so we're also looking to improve our success rates by looking at how we can improve the female situation. And again, these are the same pressures, as you can see. Just as the man, the sperm is receiving, the oocyte will also be receiving. And so the oxidation problems, and here is a mouse study where there's a decrease in oocyte quality and blastocyst number, there's decrease in fertilization rate, decrease in the development of the blastocyst, and where developmental disorders and embryo loss. So these are the kind of things we can actually pick up here. And certainly in their study, they also found better embryos and better blastocyst rate, and they had better top quality blastocysts following proxy treatment. Now, the area that inspires me most is the science. I'm most privileged to have worked in and published. This was the work I published in 1985 on the epitopes of the cytotoxic T cell response, and this was published in Cell, and it's one of the most highly quoted papers in the field. And it's actually, I'm happy to say that it does form the foundation of the current vaccines. Here's my paper on ovarian, the first case report that is actually on ovarian tissue, and one of the earliest gonadotoxic treatment on sperm quality actually defines at what point we have to give up looking for recovery of sperm. And I think this is one of the biggest papers that I have actually been associated with. But in recent times, I have published the consecutive ejaculate paper, which I think forms a very important part of what we do. So that's why I want to dwell a little bit on the science and what is DNA damage. And you know all about alkylation, hydrolysis, oxidation. We look at mismatch, single strand break, double strand break, and we know how the ionizing radiation and the oxidative will actually damage, but I mean the oocyte will repair some of it, but there are certain damage which are beyond repair. And if we look at both the physiological roles of reactive oxygen and the pathological role, well, one will affect the function of the sperm, and the other one will actually cause very lethal damage or apoptosis of the sperm here. These are your typical oxidants to the left, and these are your antioxidants to the right. All right, and although I haven't quite looked at this review again, and I think the level of I think it's a weak study if I recall, but certainly what they show, there's an increase in the live birth and pregnancy rates with antioxidant use by male partners. And within this is also another study is that the sperm motility is far better in case where the source of reactive oxygen species is less, and that the DNA fragmentation is much less again where you have less possibility of reactive oxygen species. And in terms as how it influences, it may be for pregnancy rate, it may fertilization rate, it may not influence so much between IVF and ICSI, but when it comes to the actual pregnancy rate, you will begin to see a drop depending on the level of DNA fragmentation. And there are just general problems with the detection of oxidative stress and reductive. Because we do not know what is a normal, that is the key point here. And the redox issues are also cascade into much to really is dangerous for other cells, and you have them in, we can form the same links with cancer, cardiomyopathy, blood-brain barrier, Alzheimer's, and a whole host of other things in addition to the defects of in embryology. And the question is how to measure it, is that is measuring it by the one below, which I can't really see here on my own slide, but here we are, it's a Myoxis machine, which I believe the Hammersmith and Imperial Hospital in London, they use it a lot. Now I'd be quite interested to know what sort of results they're getting here, because this might give us a clue. It might not improve your success rate, but it's a beginning as to how we can understand things in our field and improve our success rates as a result. So it is understanding the science first and then working the other way around to improve our success. And here's the redox potential in controls and patients, where in patients it's much worse in terms of normal sperm. Again, the distribution of the oxidation reduction potential, which is a measurement of the Myoxis machine, is that in patient sperm, it is really quite spread out here. Which leads me also onto the DNA damage that is caused. And if you look on the left-hand side, you see the green sperm, which have got less DNA damage, so they're going to be more fertile. And if you look on the right-hand side, you'll see when the comets go is much higher, the miscarriage rates is also much, much higher. And if on the left-hand side, if you look at the distribution for the infertile male, it almost achieves a bell curve. But literally more than half of those will have very high DNA damage within their sperm. And if we have to translate what it means for ICSI and IVF, and certainly IUI, I would imagine, although they haven't done that analysis, is that the more damage there is, the poorer will be your outcomes for IVF and ICSI here. Here, more studies that were done showing that the DNA as a predictor of IVF, where we're looking at the IVF and ICSI, just in IVF alone, with greater damage, you're going to have a lesser success rate going from left to right here, okay? I'm going to have to skip some slides here, but one that I do use quite regularly in my talks is that the odds ratio for progressive motility and the odds ratio for the sperm DNA fragmentation. These are quite significant actually to look at, and they are correlated. So what it means, and I'm going to come to this in a second here, because these are because I'm going to translate it now as to what it means for. Sorry, let me go back to here. So the DNA integrity of the can be used as a prediction to see to look at your success rates, and I think this paper was published within the Gavikamen group in human reproduction, and there's so many of these publications now. So now I'm going to focus on what you want to hear, and that is IUI and IVF, hopefully IUI. I've published quite a big paper in BMJ Open with the help of many nice people. We did a big retrospective study. This issue about consecutive ejaculate I've been practicing for many years, and the idea that if there are the women whose partners have few sperm, if you could only give them more sperm, they are the easiest group to get pregnant. And for this reason, is there a way that you can actually give them more sperm? And that's why consecutive ejaculate comes in. I have fought very vigorously, as you can see in the BMJ letter, about the NICE guidelines in the UK. So please don't believe the NICE guidelines. So let me begin by saying that the more sperm you put in, the greater will be your success rate. The better the motility, the better your success rate. The lesser the DNA fragmentation, the better your success rates. So if you were presented in a laboratory in your clinical environment with a normal sample, would you by any chance convert that patient into a severe oligozoospermic patient? And the answer is possibly yes, because if the washing and all the care that is not taken, there are several levels where you can be given a normal sample and you end up with very few sperm. And I'm sure that most of you will be able to tell me, yes, that has happened in your clinic. But is it possible to shift from an oligozoospermic patient to a normal? And the answer is also yes, because I have now shown this to you in that if you're vigorous and you can actually achieve that through the use of consecutive ejaculate, but you have to use it very cleverly, I think. But we can discuss that one also. So where in this publication, although it's a pilot study, and we have had so many successes after that, is that if we look at the pregnancies here, 23 and 19%, where we had to use consecutive ejaculate, it's because we had so few sperm. That's why we use consecutive ejaculate. And so we could actually quite easily achieve those sort of success rates. So we come on to abstinence. So consecutive ejaculate effectively is reflecting on the abstinence. One is long abstinence and the other one is a short abstinence, all right? So with a short abstinence, you have better rapid motility to the right of this chart. And the work done by Alipur, and they do some very clever computerized work here using CASA machines. And on the third ring here, they show that progressive motility with a 2-hour abstinence much better. And the DNA fragmentation with various days abstinence improves with a shorter the abstinence time here, and that over 4 days ejaculatory abstinence did actually have a detrimental effect according to Borges' paper on the DNA and the ICSI outcomes, and that 1 day was better in their opinion. So there's now a plethora of publications. Well, this is a generalized linear model, which shows that yes, the DNA fragmentation is much less in the shorter abstinence, and that if you were to consider that the blastocyst formation rates and implantation and the pregnancy rates are all much better with a shorter abstinence times. All right, and here's a continuation of the same paper where the high quality embryos were obtained for the 3-day abstinence versus 5-day abstinence. So again, it's a repeat of the other papers. So with short abstinence, you might have a decline in the sperm count and but you're actually gaining much more on the progressive motility, and I think that is a very important fact. And this is the Bashir paper, Alipour's paper, and they did amazing studies. This was done in Cape Town. They actually did this work after I presented at Eshrey in London, and they come up with very good figures showing that the short abstinence on just about many of the sperm parameters were superior. Okay, so again, the longer abstinence are also the likelihood that there will be a reactive oxygen species affected. Again, I'm going to skip 1 or 2 of the slides purely because they're repeating what has been said earlier. And I want to really bring you on to what happens at North Middlesex Hospital here. Over the years, our IUI success rates were abysmal. You know, I mean, we're looking at, so we started improving them. And these are the pregnancy rates per cycle. And the bottom graph actually shows you what percent, if 100 women walked into your clinic, what would happen? And the red line here shows what the national average is. So we have been working very diligently, and I think full credit to the nurse and the clinician and especially for them to allow me to express the way I would like things to be done and translating it into and here we do see the success rates. So we have consistently high success rates, and I believe that even at 21% per cycle, there's much more scope to improve. And I know that one or two people are actually getting, after speaking to them and guiding them, they're probably getting about 22 to 25% per cycle. But we can cross that bridge another day. Now, there's another fact, is that 70% of the women undergoing IVF will never have a baby. Now, if I say to you that 30% of the women entering, over 30% will achieve a pregnancy, gosh, isn't that similar to IVF or even better? Well, certainly, if I took the baseline success rate, it is against baseline IVF success rate, it is £45,000 cheaper to have a live IUI baby compared to an IVF baby. But if you shift over to North Middlesex, that benefit will jump to £76,000 per baby. All right. Now, the way we've done the cost analysis, and you can read it all in the BMJ Open, it's free access 2020 under Bahadur, that anything above £15,000 cost effectiveness must inform the stakeholders. And this is not even taking account of the risk of OHSS and all the hidden costs of IVF and embryo freezing and everything else that goes on. Now, if we place that against what the HFEA success rate for the birth rate in IVF is that just about these are birth rate per embryo transfer and birth rate per cycle, all right? And so even at its very best, we're not even breaching 30%. This is despite the fact that all the clinics will say, we have a success, we are doing very, very well, thank you. We have a success rate of 40 to 75% pregnancy rates, but why is it that the live birth rate is so low then? You know, what's happened in between? And I fear that we absolutely need to revisit this area in terms of ROS damage. Is there miscarriages, DNA fragmentation? We need to begin that it may be an aberration. It may be the way we look at things, but why is it that we have not, with all the mighty add-ons and everything else that we have at our disposal, that we have not breached more than 30%? I mean, of course, people are breaching that, but they're in selected populations. You know, there's a whole marketing industry out there. And yes, we are told that it's all wonderful because we've now have a very low multiple birth rate. But remember, the multiple birth rate is still, even if you reach 10%, it's still 8% more, 8% more than the background. And it's a lot higher than the IUI multiple birth rates, okay? Then the question is, how many IUI cycles and IVF cycles do we need to match to get one live birth? But initially, just one IVF cycle, from our study is equivalent to 2.35 IUI cycle, using the baseline success rates, the real success rates. But if you were to move to North Middlesex Hospital, you need 1.73 IUI cycles against one IVF cycle, all right? And this sort of relationship is not very different if you think in terms of if you were to consider mid-IVF and an upper IVF, but I wouldn't go to an upper IVF because there are many other problems, because when you do the cost-effective and risk analysis, in fact, it is better than to go to the mid-IVF clinic at the end of the day. And then if you want to achieve one live birth, you need to have 3.7 IVF standard cycles or 8.69 IUI cycles. So if you go to North Middlesex, you need 6.4 IUI cycles. All right, and we've also done a very big cost analysis of the neonatal and maternal burden through multiple births, and IVF is a big hidden contributor which the national purse does not see. And in typical Gujarati style financial analysis, we created these models using the standard IVF success rates and the standard IUI success rates. And this model actually tells you when IUI becomes cost ineffective, all right? And using baseline success rates taken from the HFA data, it is actually £42,000 cheaper to have an IUI baby, whereas if you go to North Middlesex, it is £76,000 cheaper. So there is a real effect for patients here, all right? And then if you were to see what baseline 12.1 IUI baseline live birth rate against IVF is that IVF needs to actually match up to 32.58%, which is not being achieved right now, all right? And if you were to match the success rate of North Middlesex Hospital, IVF actually need to push their success rate to 42%, which is really quite not possible at the moment. It has not been achieved, and therefore it is worth investing in IUI because that is the cheapest option here for you. I think I have spoken long enough. I'm so sorry that I have some sticking points on my computer because I couldn't move the slides, but I'm going to conclude my talk for you. Men not associated with pregnancies begin to think outside the box. Use consecutive ejaculate as your main option when you come to men, but there are other things I haven't told you about as to how you can work around it to get even more sperm. The definition of mild to mid male factor infertility is not credible. It doesn't exist. There's nothing written down. And that the WHO manual is only valid for men associated with pregnancies. It says nothing about men who are in a subfertile situation. I appeal to everyone, investigate the man, don't treat them as sperm vendors, but treat them as patients, please. Male subfertility is an early warning sign to monitoring their health. You can spend billions of pounds on early detection systems for various diseases. They're sitting right in front of you. You could actually do something quite positive also in addition to treating them for their subfertile situation. Unexplained infertility. There is no discipline in medicine that can give a definitive treatment. Think about it. If you were to say for an unexplained heart murmur and somebody offers you that you need a heart transplant, you would not take it. Okay, so I'm going to have a cheeky swipe at UK heterosexual encounters, and that is that the heterosexual encounters, only 0.09% of heterosexual encounters in the UK leads to a baby. So I think that's not very efficient. Maybe we should offer them IVF, ICSI, IUI, I don't know. But thank you for listening to me.
Thank you so much, sir, indeed. Amit, sir.
Yeah, I would like to start my screen share. Gulam, that was an excellent exposition. And your last slide says it all. It's a very tiring job, but nevertheless, I think you have brought out very fine nuances of male infertility investigations and trying to understand it. I will start my talk thanking Shield Connect for an excellent opportunity to connect with Gulam. Fond memories of Homerton Hospital where I worked, although I didn't get a chance to work with Gulam, but nevertheless. So good evening, ladies and gentlemen, and thank you, Dr. Sarita and Dr. Archana, for hosting this on the West Zone AICC RCOG platform. My talk is going to be on how and why of male infertility. There is going to be some amount of overlap between our talks, but I would like to take up first some of the definitions of the abnormal serum parameters. Azoospermia is when spermatozoa cannot be found in a semen sample. It's not so easy. I would request somebody to screen the person twice, and further to do to check the pellet after centrifugation, because almost 2% of so-called azoospermic men do have the sperms when you actually centrifugate and check the pellet. Oligospermia is when the sperm counts are less than 15 million. Asthenozoospermia, less than 50% of spermatozoas exhibiting forward motility. Teratozoospermia, but the strict Krugler criteria, normal sperm counts less than 5%. Aspermia, when no semen sample is ejaculated at orgasm. Necrozoospermia, when all spermatozoa in the semen sample are dead. and globozoospermia, when none of the sperms have an acrosome cap, and this can be seen only when you do a staining of the smear and not when you're actually seeing for the motility. As Ghulam has rightly said, assess the male partner, go into their history, past history of any illnesses. In our country, tuberculosis does lead to oligo and azoospermia. Developmental history of puberty, undescended testes, medical history for mums, surgical history, especially as a neonate or as a young child for any orchidopexy or hernioplasty, any history of chemo, radiotherapy, which you'll obviously get from the young man. Habits, occupations do affect drugs for hypertension, diabetes, and the medical problems of hypertension and diabetes will affect sperm, especially the DNA fragmentation, and to get into their sexual history. A good assessment of a male begins with a general examination for their hair distribution, for their secondary sexual characters, breast examination, and do not always rely on history. Also look for surgical scars, especially in the genital region or in the inguinal region. On a local examination, look for the penis, the urethral meatus opening, examine for the testes, the testicular volume, the turgidity of the testes, look for varicocele. Assessment of male factor, when we know that there is some amount of abnormal semen parameters, we try to look for any specific medical problem, look for varicocele. If the varicocele is palpable and one or more of the parameters are abnormal, you could consider varicocelectomy. As Ghulam has rightly said, go for IUI, and if not, if the sperm parameters are extremely low, the patient may need ART. Specific medical managements for reversible cause, hormonal deficiencies, hypothyroidism, hyperprolactinemia, and non-specific treatment with antioxidants. Now, what is this reactive oxygen species, ROS? It is a highly reactive oxidizing agent, and it needs continuous inactivation by antioxidants. So we need to keep a balance between the ROS and the antioxidants, because both are essential. ROS is required for normal semen function, particularly like capacitation, acrosome reaction, and sperm oocyte fusion. So it needs to be continuously inactivated by antioxidants. And whenever there is excess of ROS, you will find that there would be some problems. So when the ROS is increased as in relation to antioxidants, you would find that in almost 25 to 40% of the infertile men, it will cause damage of the plasma membrane, increases DNA fragmentation, decreases fertilization, can give you fragmentation in the embryos, early apoptosis or early embryo death, and will also be found in cases where there are an increased amount of abnormal sperms, highest with immature or abnormal head sperms. And as the sperms get into maturity, you will find that the ROS will decrease. Look for infections. If there is more pus cells, you would find that the ROS is increased. And also ROS is increased if you centrifugate the sperms at higher duration or for an increased time or increased spin moments. So when the ratio between ROS and TAC is low, you would get lower pregnancy rates, which means that in men with varicocele, you'll find that the ROS is increased. Post varicocelectomy, you will find that the ROS decreases and you would get an increased pregnancy rates in spite of no major changes in the seminal parameters. And that is what it is. You'll find that the sperm DNA fragmentation would reduce. How do you treat increased ROS? You could decrease ROS by treating with antibiotics if there's presence of pus cells, if by supplementation with good medias, oral supplementation with antioxidants, shorter centrifugation time, and as Gulam has rightly put, reduce the abstinent times. Nowadays, we specifically tell men not to have prolonged abstinence because quite often couples would abstain from sex or the men would abstain from masturbation when they are on treatment. We specifically tell them to ejaculate and reduce the abstinent times, particularly in an IUI or even in an IVF cycle. We tell them not to have more than 1 day of abstinence because of the brilliant papers that have come out from North Middlesex Hospital. Putting them on oral antioxidants will improve the ICSI outcomes in men with increased DNA fragmentation. Now, there are various different antioxidants that are used. I'll very briefly touch on them. But when you take sperm DNA fragmentation as a prognostic indicator for ART outcomes, you find that there's a negative correlation between the rate of fragmentation and sperm characteristics. Again, a negative statistical relation for sperm DNA fragmentation and fertilization, be it IVF or even with ICSI. When DFI exceeds 25%, you get almost 18% of embryos on ICSI getting arrested and increase in the miscarriage rate fourfold. Now, various antioxidants, the most easily and cheaply available are the vitamin C, antioxidant like vitamin E, which can be very easily procured and can be easily supplemented by giving them supplements. Coexam Q, CoQ10 is a new kid on the block, which has been there for quite a few years, but expensive. Recommended dose would be 60 milligrams per day. And then the rest of them could be selenium, glutathione, zinc, and arginine. Not going to specify on any one, but if you ask me to put my finger on any one, it would be vitamin C and vitamin E, and nowadays CoQ given in the right dose. The general guidelines are to treat for minimum of 3 to 6 months, at least for one spermatogenic cycle, and wait and see to see if any improvement happens, particularly in the sperm DNA fragmentation test. Varicocele has taken a comeback again. Veins, we know it is the dilatation and engorgement of the veins which drain blood away from the testes. But varicocele is found even in normal fertile men. So treat varicocele only if it is going to affect the sperm parameters. How it affects, it increases hyperthermia, increases hypoxia, apoptosis, increases ROS, and men who smoke and have varicocele have a 10-fold increase in the incidence of oligospermia. The American Urological Association and the ASRM has recommended varicocele treatment only if the varicocele is palpable. So do not send men for scrotal Dopplers because you would pick up a large number of men who may not need the surgery. The couple has documented infertility. The female has normal or treatable infertility, and one or more of the semen parameters are abnormal. Predictive factor is if the varicocele is grade 3 and the testicular volume and turgidity is maintained. If you have got varicocele with testicular atrophy, you would have a very low success despite doing the treatment. In men in whom the FSH is normal and not raised would do better off with treatment for varicocele. And where you find that there is an improvement, you have to wait for at least 2 to 3 months. Sperm washing as an IUI, we all know, will remove the dead sperm, will concentrate the sperm into a small volume, will reduce the prostaglandin reaction, anti-motility and anti-capacitation factors. Not going to get into more details of this, but nevertheless to say that if you get men with azoospermia, I think it is important to check on at least 2 semen samples. And to go one step ahead, you must centrifugate the sample and check the pellet, because as I said earlier, 2 to 5% of the so-called men who are labeled as azoospermic would have sperm in the pellets or in the centrifuge sample. 2 types of azoospermia, the obstructive and the non-obstructive. The obstructive azoospermia would have fructose negative on a semen analysis, would have a low semen volume, and on examination would have a normal or by far normal testicular volume. When you try to look for the vas, you would find that there could be absence of vas, and congenital bilateral absence of vas is something that you need to look at differently because it is associated with some amount of genetic problems. You could also look for seminal vesicle obstruction or ejaculatory duct obstruction, which can be found on a transrectal sonography. Now, some men with obstructive azoospermia can be treated surgically, but quite often we find that these men would also prefer, or the unit would prefer to subject them to ICSI and to sperms which are retrieved on PISA. On congenital bilateral absence of vas, you have to rule out genetic abnormalities. And as I said, the technique for an obstructive azoospermia would be to go with a percutaneous PISA rather than actually taking the sperms directly from the testes. The other major group is the non-obstructive azoospermia, where there is fructose present on the semen analysis, a normal semen volume because there is no obstruction, and most of the semen volume is contributed by the seminal vesicles and the ejaculatory ducts and the prostatic fluid. But on examination, you will find that the testes could be small, could be soft, and quite often you will have a flat epididymis. On hormonal examination, you would find that there is an elevated FSH with normal or near normal testosterone and estradiol levels. The way to obtain sperms would be TISA or even micro TISA nowadays. All couples with non-obstructive azoospermia have to be counseled for the risk of not getting sperms, and these couples then should be counseled whether they would want to proceed ahead with the potential use of donor spermatozoa if sperms are not identified in the testicular tissue. And quite often we would want to do a TSA in the prior cycle, freeze the sample, and then proceed ahead with the stimulation for the woman. Whenever a testicular biopsy is done, the most advanced spermatogenic pattern, as opposed to the predominant pattern, will give you will affect the results of the semen retrieval. So even in men who have at least one area of hypospermatogenesis, you could have almost an 80% surety of getting spermatozoa on retrieval with TSA. For men with a histopathology report of maturation arrest, you would find that spermatozoa will be obtained in at least 40%. And quite often when you get a histopathology report of Sertoli cell syndrome, because that is the most predominant pattern, you would get semen, you would get sperms in at least 20 to 25% of these men. And that is where micro TSA comes into play, where you can do multiple punctures. It's a very long drawn procedure, would take a long time, but you would get sperms obtained in micro TSA. The thinking nowadays is that when there are very, very few sperms which are found in the ejaculate, instead of using these sperms, we would want to go directly for the testicular obtained sperm. And that is because the DNA fragmentation in the ejaculate sperm may be very high. And we know that sperms obtained from testicular biopsies would have lower sperm DNA fragmentation. And we now know that would give us better fertilizations and better clinical pregnancy rates. When would you use a scrotal USG and a Doppler? Should be strongly considered in patients with cryptorchidism or prior germ cell tumors, or in men who have unexplained abnormalities on testicular examinations. Routine scrotal Dopplers for subclinical varicocele is not recommended because repair of such varicoceles has not shown to have much effect in improving semen parameters or even giving you better clinical pregnancy rates. When you have men with hypo, where the LH and the FSH is remarkably reduced, less than 1, the differential diagnosis could be pituitary tumors, Kalman syndromes, men on anabolic steroids. But nowadays we see it in grossly and morbidly obese men also. So morbid obesity also can give rise to hypo. And this is something that has to be explained to the patients. That weight loss would help them. And quite often you find that men who undergo bariatric surgeries with comorbidities of hypertension and diabetes do very well a few months later, even on their semen parameters. But needless to say that if men have got genuine hypo, the treatment would be to putting them on GnRH pulsatile or subcutaneous doses, or the easy method would be to put them on HMG injections, 150 IU, given bi-weekly for almost 90 days. Now, quite often when we do testosterone, we find that some of the infertile men could have low testosterone. And when you have low testosterone E2 ratios, I think it would be worthwhile treating only this group of men with anastrozole, 1 milligram per day. For men with Klinefelter syndrome, response is better using testalactone, 50 to 100 milligrams per day. Treatment for hyperprolactinemas is same as you would treat the females with dopamine agonist, and if they have got pituitary tumors, maybe transnasal surgeries. Men with idiopathic OATs, there is no evidence to treat them with any androgens, HMGs, HCGs, or even with anti-estrogen or prolactin inhibitors or steroids. When men come with hypergonadotrophic hypogonadism, where the LH, FSH are remarkably raised, it is a sign of testicular failure or a dysgenesis, Klinefelters, anorchias, cytotoxic medications, or even radiations. We now come to ICSI, and although ICSI we know was never went through the grill of having any scientific phase trials, we know it is a highly effective therapeutic intervention and has truly revolutionized male factor infertility. But we know that there are drawbacks. It bypasses the effective biologic mechanism of sperm selection. It has not been applied to human reproduction by research trials and even in mammals. And the human experience with ICSI is the experimental record. And we know that men with severe OAT and in whom we have used ICSI has the potential to negatively impact the genetic composition of the human population. And why? This is the slide that shows that almost in 13% of azoospermic men, you would have karyotypic abnormalities, and almost 15% of azoospermic men would have Y chromosome microdeletion. Now, this comes down in men with severe OAT in counts of less than 5 million. 5% of them could have karyotypic abnormalities, and almost 7% of them could have Y microdeletions. And that is a concern that is there in men in whom are not adequately investigated that you do ICSI. Bilateral absence of VAS is associated with cystic fibrosis. You would want to test the most common 16 or 18 genes. Unfortunately, in India, not many centers do all the mutations, but the most common mutation of Delta 508 is done in most labs. Y microdeletion for azoospermic and severe oligospermic men, and in rest of them you would want to rule out any structural defects or aneuploidies. Now, what is this Y microdeletion? Most of the deletions are in the 5 and 6 area of the Q arm of of the Y chromosome, which is the AZFA, AZFB, and AZFC region. We know that that in addition to these three, there are 15 novel genes which are identified on Y chromosome, and various other genes like the DFFRY or the RBM or the DAS genes are associated with male infertility. Now, although this is not a watertight compartment, we know that if there is presence of AZFA deletion, you would get Sertoli cell syndrome. If there is deletion of AZFB, you could get spermatogenic arrest. And if there is deletion of AZFC, you would get a maturation arrest of post-meiotic germ cells. As I said, that it is not a watertight compartment. Quite often we know that there could be no correlation between the severity of spermatogenic defect and the localization and the extent of the Y chromosome deletions. And genotype-phenotype correlations are quite difficult to sometimes establish. There are other genes outside the AZF which will modulate the effects of the AZF deletions. And we know that in men who have these AZF deletions, it is possible that in their young age, they could have spermatogenesis, and these genes get activated maybe in the third or the fourth decade of life. And quite often, if you have identified men with Y microdeletions, you would want to freeze their multiple semen samples, because we know that they could rapidly go from oligo to azoospermic. We also do fish on sperms, where we find that there is abnormality at the end organ, and quite often this is the reason that despite having a normal karyotype or no absence of Y microdeletion, you could have an abnormal sperm, which will obviously give you abnormal embryos, and that is why you have the problems. I've already spoken on cystic fibrosis associated with congenital bilateral absence of VAS, can present with delayed puberty or with azoospermia or general infertility. So in azoospermic men or men with severe OAT, I think it is an integral part to counsel them for genetic testing, normal karyotyping, Y microdeletions, and in men with bilateral absence of VAS to also see for cystic fibrosis. As Gulam has rightly said, that it is important to look for associated medical problems, and he's also mentioned about the relation between testicular cancers and azoospermia. So I think it is extremely important that if you take a testicular biopsy, it is worthwhile sending a small sample to rule out testicular carcinoma in situ, because almost 2 to 3% of men of azoospermia or with severe OAT will have carcinoma in situ. So it is important to follow up these men even after they've finished their ART treatment. In hypogonadism, androgen replacement after completion of infertility treatment is very important. In men with borderline testosterone or LH levels need to be assessed every 2 to 3 years. And on sonography, if you find that there is testicular microlithiasis, lot of calcification in the testes, I think you need to do a testicular biopsy, if not done earlier, to rule out carcinoma in situ. Like to thank Gulam for his wonderful lecture, and I would like to thank the audience for a patient hearing. I think we are both open to any questions which can come up on the chat box. Thank you so much.
Thank you, Dr. Patke sir. Thank you very much. And Dr. Bahadur sir, thank you very much for your talks. I'm Dr. Prachi from Shield Healthcare. I would read out the questions when the participants are putting those questions in the box. To begin with, sir, I have a question. With semen analysis, is it recommended to do sperm DNA fragmentation testing as well? At the same time.
Gulam, would you like to take this question?
Yes. It's not, I mean, although I'd love to recommend it in routine use, I think the price, there's a price issue here. You know, I mean, if there was no price issue, I would say yes, I would recommend for everyone, because it is quite clear that there are big issues relating to the fertility, to the actual pregnancy, and not only fertilization rate, the pregnancy and the live birth. And I think you can actually work it backwards. There's something to do with the DNA fragmentation. And Professor Lewis has actually provided quite compelling data already, and I'm grateful to her because I've borrowed some of her slides here. But the answer is yes, I would recommend it, but whether it is worthy and whether it's going to be practical in the real life, if the prices come down, yes, I think the answer is yes.
I would give a similar corollary of doing AMH in every infertile female. Again, the price issue is something that inhibits us from asking it for every person. So the same thing happens with male infertility. Although we know that it's a very good prognostic and has a very good correlation, the price sometimes inhibits you from doing it. Having said that, in men with severe OAT or with failed fertilization, or if you find that there is lot of fragmentation happening, you may want to do it because it very well correlates with their comorbidities. It very well correlates with their habits of smoking, alcohol, and various other drug ingestions.
Right, sir. Thank you very much. Thank you, Bahadur sir. Thank you, Patke sir. The next question is, there are multiple tests available for fragmentation. COMET, TUNNEL, SCSA. So which would be the recommended test? In your clinical practices, as per your clinical experiences, in case the patient decides or the doctor prescribes DNA fragmentation test, which is preferable?
I mean, I have no, it's very difficult because I think one is a question of validation, and
Yes.
the second is a question of cost.
Yes.
I think I have a funny feeling that there won't be much difference between either tunnel or comet at the end of the day. I mean, the good thing with a comet is that the person who's leading this work actually has done a hell of a lot of studies to correlate it to pregnancy rates, live birth rates, and miscarriage rates. So she is doing, that's Professor Sheena Lewis in Belfast. I mean, she's a very prominent person. So, I mean, personally, I would have no bias towards anything. I mean, if the costs were really acceptable, down, I would personally would make that part and parcel because when I showed you the initial slide, I showed just how much of the unknowns on the sperm they exist. And I think this is where we need to really focus on, because it's not only just the man, it's also the future generation that it's affecting.
Correct. Absolutely.
Right, sir. Right, sir. Thank you very much. Patki sir, do you want to comment?
Vinam, I want to ask you a question. So now, routinely in your clinic at the North Middlesex, you ask your patients for IUI for only 1 day abstinence, or you don't tell them any abstinence at all?
No, it's a good question. I mean, what we do is we would profile the patient beforehand, and then work out. And now you're going to fall down when I tell you just the opposite. And that is where there are very few numbers, I would need to work out whether we can actually increase the sperm numbers with a lengthy abstinence, like 15, 20 day. Now, you'll say, well, hang on, you've been telling us just the opposite all the way through. But there's some method in this madness, and that is what you're trying to do is increase the cell turnover, because you've got nothing else that you can do with these patients. So you're going to see if you're going to increase the cell turnover just with a view to getting more sperm on the day, because you will not be able to, although having said that, it may just be that there will be enough motile sperm. But what the plan would then be to catch the consecutive ejaculate, which is normally produced within 15 minutes of the first, you know. And when you get the second one, you'll be shocked to see how good that second sample is. I've had one case, and I'll tell you, I think it was 4 million, and I've spoken on Mr. Anil Goody's talks, fertility courses. If I recall, it was something like 4 million per milliliter. And then the consecutive ejaculate was something silly like 80 million, and you couldn't believe, you know, and you think, where did that sperm come from? But although the volume was less, I mean, you could actually virtually take all the sperm and achieve for the intrauterine. It makes it a viable process. And of course, you are also going to recommend that they have sex afterwards. So it's not just a laboratory clinical based process, because you know, it doesn't matter at the end of the day. We have set out to achieve a pregnancy. That is why your patients have come to us. They haven't come to look at us and see how clever Dr. Bahadur is. They simply want a baby, and they don't care anything more, you know.
Would you apply the same logic if you are doing IVF, that you would want to reduce the incidence, or even ICSI for that matter, or you would rely on some gadgets which can pick up better sperms, or where you can magnify and pick up better sperms?
Very good question, because there are some sperm separation gadgets that are on the market, and I believe they're very, very good, of the very few I've seen, you know. And in fact, for some clinics, especially on a Saturday, Sunday, if you're inseminating and the lab is not there, you could actually just place the sperm in one section, collect the sperm in the other section, and directly inseminate. So, I mean, but I think those also are expensive little gadgets, or what you call devices, which are one-use, obviously disposable, but they are expensive. But looked against the cost of running the laboratory on a Saturday or a Sunday when you have to bring in your staff, or maybe sometimes you just want in unknown, where you've tried your best, and you then think, well, hang on, can I actually get very, very good quality sperm using this method? And the answer you need to be open and assess it for yourselves. And I suspect that you might actually have a very positive answer and potential use of that gadget.
All right. Thank you.
Yeah, thank you, doctors. Thank you, Dr. Amit Patki and Dr. Gulam sir, for being there and giving this lecture for us. Thanks. It's an honor for us that to have you all as a speaker, and also including RCOG West Zone. Thank you, sir.
Thank you very much. And thank you, Gulam, for spending your Friday afternoon, stroke evening with us. And hope to see you more often, giving us some very good scientific and evidence-based knowledge. Thank you very much.
Pleasure. Thank you. Thank you. Bye-bye.
Thank you, Dr.
Thank you
Prachi
very
and
much.
Chitrikala.
Thank you, Bahadur sir. Thank you, Patki sir. Thank you.
We can log off.